All right. So I think maybe we should begin. Welcome. My name is Helena Hansen, and I'm at UCLA. I'm a proud member of the organizing committee for this seminar series called Confronting the Drug War, Drug User-Oriented Harm Reduction and Drug Policy. And I want to, first of all, give you the title of this week's seminar, which is Deconstructing the Brain Disease Model of Addiction. And we have 4 amazing panelists, each of whom is very distinguished in their area of critical scholarship on addiction and substance use and drug policy. So we're going to hear from Nancy Campbell, Sterling Johnson, Nicole Luongo, and Anna Kvenli. I'm going to ask each of them to introduce themselves in turn. So we have a series of questions that we're going to ask them to open up by answering, and this is very much a roundtable format, so we're hoping for crosstalk and conversation. But I want to start by acknowledging that early proponents of the disease model of addiction, quote unquote, chronic relapsing brain disease that was very heavily promoted in the 1990s, particularly in the US, where we had our Decade of the Brain, launched by the first President Bush with a hope to find the molecular causes of a whole lot of problems, including substance-related problems. I want to acknowledge how the early proponents of this chronic brain disease model thought that it was a more humane alternative to the moralistic and criminalizing models for viewing and thinking about substance use. But today we're going to explore the trade-offs, since the medical system is in a lot of ways not equipped to serve people who use drugs. And it's kind of absolved itself of the best treatments and services that people who use drugs really need. And in addition to that, the chronic relapsing brain disease model of addiction pathologizes drug use and minimizes the autonomy, the self-determination, and alternative pathways to self-defined recovery or well-being that people who use drugs, really benefit from. These may or may not involve abstinence, treatment in the biomedical system, or medications. So I'm going to begin with our first discussion question, which is, why was the disease model that I just mentioned, chronic relapsing brain disease, for example, why was this disease model of substance use initially adopted? So I'm going to ask first Nancy Campbell and then Anna Kvenli to comment on how the disease model initially replaced a moral model. And I want to ask each of them to very briefly introduce themselves in the course of answering that question. Thank you.
Certainly, thank you. My name is Nancy Campbell, and I'm actually a historian of science, medicine, and technology who specializes in drugs and drug addiction, drug policy, and drug treatment. And I would have to say that we have been looking for a scientific cure for the opium problem, which was what we called it 100 years ago. When U.S. Public Health Service researchers began to try to figure out how to counter criminalization by placing drug addiction under the banner of medicine and public health. So I wrote a book about that. I'm a faculty member at Rensselaer Polytechnic Institute in Troy, New York, and I wrote a book called Discovering Addiction on the Science and Politics of Substance Abuse Research. And that was about that search. And it was about the it's really a parade of disease concepts that are very much recyclings and regurgitations almost of moral models that are melded with scientific terminology and scientific concepts. And so when we look at, say, the metabolic disease model, concept that underlies methadone maintenance, or behavioral science, which tried to destigmatize by getting away from use of the term addiction and to use abuse and use and all of those kinds of things and emphasize behavior and not the substance itself. I'm the historian of that. So that's my little introduction, and now I'll try to answer your question, Helena. We should always ask what kind of disease we're really talking about. Is it allergy-like disease, heart disease, diabetes? Is it more like mental illness or more like brain damage? And I would suggest that today's concept is more like the latter, and that should give us some cause for concern. Is it more like a contagious disease that spreads through unmarked carriers? Is it more like an infectious disease where individuals are somehow marked as having that label of that disease? So addiction was reframed as a chronic relapsing brain disorder during the decade of the brain, which actually coincided rather nicely in my case with when I went to graduate school and got interested in this question about how addiction was being framed, and whether that the science of addiction research, how did it get a handle on thinking about this kind of social life? Because what I was seeing unfold around me was social life. And it so happened that in the 1990s, the state of addiction research was considered by many people, including the National Academies of Science, as a dismal science. And so neuroscientists were actually recruited to study addiction, which they had not formally shown any interest in, by this assertion that addiction is a chronic relapsing brain disease. The new definition, and really this recruited an army of neuroscientists. Many of you are probably listening in the audience, but the new definition focused on the brain as the locus of addiction, the target organ of treatment, right? The idea that we could directly somehow reach the brain, first pharmacologically, and today non-pharmacologically, comes from that era, and as the central actor in a damage-centered drama. And these folks were supposed to produce basic scientific knowledge that would destigmatize addiction, and it would work hand in hand with clinicians to actually come up with treatments that worked in evidence-based practices. And instead of those ideas, I would have to say, they were best at installing a new neuroscientific orthodoxy that took over all of the other flourishing sciences of addiction, including social sciences and sciences that anthropologists and ethnographers who were much more culturally embedded, and they marginalized all other ways of knowing drug use that were more socially contextualized. And they produced in that process, unfortunately, new forms of stigma based on brain damage. And I think that model always carries a moral charge. It always carries with it the history of the ways in which people who are neurodivergent are taken into or cast out of society. And so that moral charge, every generation can, in a sense, we have to say, we all have moral models. It's just that they're alloyed, in our case, to neuroscience. And that reinscribes the idea that the brain reward system is what's messed up when it comes to people who use drugs. That's the problem. The brain reward system is the problem. And so tinkering with brain circuitry is the solution. And that is an epistemic injustice, in my view. It flattens and obscures the differential histories and cultural geographies that force us to ask the very inconvenient question for neuroscientists, just whose brains are we talking about here?
Thanks so much, Anna. Would you like to weigh
Yeah.
in?
Oh, thank you, Nancy. That's amazing. So I'm Anne Kveim Lie. I'm an associate professor at the University of Oslo, where I teach in medical school. I've been teaching together with user activists and representatives from user organizations, social medicine and drug use for 10 years. And I've also been I'm a medical historian, so I've been doing research on the history of definitions of drug use, or problematic drug use, and also some history of policymaking. This has but I've also been really interested in the increasing medicalization and biomedicalization in our everyday lives, how medicine has taken over and spaces that previously were not a field of medicine. So my interest in this panel also goes into that research. So I don't want to spend too much time on, because my knowledge is about European history in this field, and it sort of differs in some important ways. And I thought that might be interesting for you as a contrast. I don't want to spend too much time on it, but just to say that within many of the European countries, black market for drug use was not a big problem until the 1950s, 60s. So before that, drug use was primarily, I mean, use of opioids and other stimulants were considered a problem of medicine, created by medicine, by physicians prescribing too many medicines. And it was considered also a problem to be handled by medicine alone and not considered sort of this public problem. So a very different story. We saw, so it was already medicalized in a sense, more so than alcohol use, which was, medicalized during the 40s and 50s. And these two were sort of increasingly in contact with each other and considered part of the same problem. And this changed rapidly in the course of the 60s, particularly when sort of the black market was increasing and, young people, this story, whereby and also it's coinciding with the 1970s focusing on social practices and social conditions as cause of all kinds of problems, including medical problems. So we went from sort of a medicalized approach to a very much sort of psychological, behavioral oriented therapy where abstinence was considered the only option. And we had been doing substitution treatment before within these medical systems, but now that was really considered not something that you should do. And for a long time, and maybe we can talk about that later, abstinence was sort of the only option, considered the only option, and in different treatment positions. And it was actually it was not treated within the health system. It was moved out of the health system, the medical system, and into sort of the social problem system. And it took until after the HIV pandemic before it sort of re-entered the medical field. So I'm talking about, I know more about the Scandinavian system, but so some of these things would not be correct for other European countries, but more or less, I think this is a broad pattern that you see. An interesting thing in the Nordic countries is that they actually come together, all the Nordic countries, and declare not a war on drugs, but a sort of vision for a drug-free society. So it's the society that they claim should be free of drugs, and thereby just erasing drug use as pleasure, as, belonging to life in whatever sense. So this was a policy agreement that lasted for 20 years.
Thank you. And hopefully we'll get a chance to revisit these themes in our discussion. I wanted to go to the second question, which is, how does moralism manifest itself within the disease model? What is the impact of the disease model on stigma, racialization, structural factors, and the experiences of people who use drugs? So for this, I'm going to ask Nicole and Sterling to weigh in.
Hi, everyone. My name is Nicole Luongo. I'm calling in from the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people, otherwise known as Vancouver, BC, Canada. I do have an academic background in medical sociology, although these days do not work in academia. I work for a national drug policy organization. I'll just jump into the question. So when it comes to kind of morality, we know that kind of white Christian perceptions of morality are inherent to the disease model. We've never actually moved away from that. And I really would just want to emphasize the extent to which the disease model is kind of rife with these logical and epistemological contradictions. When people are diagnosed with substance use disorders, we, I'll also add that I'm approaching this work from extensive experiential expertise, if you will. But when we are diagnosed with substance use disorders, we are kind of framed as having relinquished our agency, right? We've lost control of our cognitions, our behaviors, and concurrently, we are positioned as being solely responsible for getting better or for recovering. And so we see this kind of marriage or twinning of sickness and badness paradigms, and we can't decide on one or the other. Aaron Dedge refers to this as kind of the responsibilization, pathologization paradox. And drawing from Peter Conrad, Joseph Snyder, this kind of marriage really individualizes and depoliticizes substance use because it excludes the structural and systemic drivers of what gets labeled as addiction. And it also obscures the extent to which perceptions of drug use and the meanings we attach to it are, of course, racialized, classed, gendered. And for, to provide an example, two people can have identical drug consumption patterns, but only one of us might get diagnosed with addiction or a substance use disorder because that person may be visibly poor, homeless, or otherwise kind of passing within the medical/criminal justice system's frame of reference. And so the implications of this are myriad. We see drug-related policies getting kind of reoriented from political ones and political questions of equity and justice to just kind of these very technological ones or technocratic ones of implementation. And so that absolves the state and kind of the systems we're all embedded in from their culpability in perpetuating systemic oppression. And I just want to briefly touch on stigma. The notion that someone is incapable of exercising agency is innately stigmatizing. We cannot say someone has no control over their thoughts, their behavior, and not expect that to be stigmatizing, even though that was kind of the promise of the brain disease model. But we know from decades of research at this point that those of us who are diagnosed with SUDs were seen as unreliable, incompetent, untrustworthy. And so that invites this multi-sectoral discrimination. And it makes ongoing oppression via, for example, involuntary engagement with the medical system and related forms of surveillance and control seen as natural and inevitable and even benevolent because we are too sick to correctly identify our needs. And I'll also just acknowledge that this also gives way, or it can anyway, to a lot of internalized stigma. That is maybe not something that's talked about as much, but this idea that becomes instilled in us when we are kind of pushed into these institutional trajectories of medical system engagement, being told repeatedly over and over, whether that be from doctors, psychiatrists, 12-step or abstinence-based addiction treatment, that we can't trust ourselves, that our brains are broken. Speaking from extensive lived experience, that does a number on our subjectivities. And I think many of us learn to see ourselves through that medical lens and begin self-surveilling. And we know also from research that that leads often or can be a contributing factor to accidental overdose and fatal overdose. If someone is in, for example, addiction treatment, internalizes that narrative, and then leaves and resumes substance use, we are more inclined to see ourselves as having failed to adhere to kind of these very rigid conceptions of recovery. And then in addition to just the pharmacologic dangers of resuming substance use after a period of abstinence, there is those additional layers of shame and self-stigma. So I will leave it at that.
Thank you so much. Sterling?
Thank you, Elena, and thank you everyone that has gone before me, Nancy and then Nicole. My name is Sterling Johnson. I have they pronouns. I'm a person who uses drugs, mainly stimulant user. I'm a member of the National Survivors Union. Generally, I've been a housing and harm reduction and activist in Philadelphia since 2013, about 10 years. I'm a lawyer, current PhD student at Temple University. I'm on Lenape poking land, unceded territory, as well. And I guess I like to think about when we're talking about moralism and also the kind of understanding, at least from this space, of what happened on the place where I live, Lenape, Hoking, it was mainly Quakers that came to Pennsylvania, to this place, and built their society. And a lot of what they thought about was ways to be benevolent and to like accept people. And they were some of the first that would not have slavery in their societies as well. Regardless of that, they also invented solitary confinement as a therapeutic way for people to be healthy. Think that from this, we at least, just to go to now, just like understanding like what we need to do in the space, it really kind of has this understanding of the intolerance for any sort of difference within our spaces, and there is a certain understanding that never changes of what is normal and what is natural, that remains constant, whether it's benevolent or whether it's actually hostile and genocidal. So some of the ways that the kind of the paradigms that we live in allow us to think about, if you are actually different from any of those spaces, then you shouldn't get access to resources. If you're not acting in the sort of way that it's supposed to, what is natural or what is outside of what is normative, what is patriarchal, what is white, what is heterosexual, then there is something wrong with you. And the way that our country is structured is anything that you receive is actually a favor. And you should be grateful for it. As a Black person, as a queer person, as a disabled person, I would say as a disabled person, mostly disability justice is, and more the frame that I come from, or Mad Pride, as well as like, I am proud to be disabled. I identify as disabled. I'm proud to be queer. I'm proud to be Black. These are things that when, and I'm HIV positive, but there's a pride in knowing that you're part of this movements that have fought for justice in the world. When we talk about, I think it's really important for us to think about the importance of, I guess, the framing of that as not being different, as not being outside of people that, of the definition of human. So, I just wanted to give a little bit of this perspective around what is the moralism, what are the frames, what is the paradigm in which we see, but like that certainly has to be expanded. And the ways that, as I know we're going to go into that soon, Elena, like the ways that like we should be pushing it, like allows for us all to think of the human category and all of the things that go along with the structural factors that determine someone's life, like education and employment and housing and also the right to have pleasure and to be with people in community. Those things are human rights. There's nothing that you have to prove for those things to accrue to you. And I think we see some examples through this, and I want us to really push back on every single time that anybody ever said that something was given to you. I can assure you that the people that were experiencing it actually say themselves. It's like Black people free themselves. Abraham Lincoln did not free us, right? Queer people fought for the right to get HIV meds so that we could live our lives. The only reason I am here is because queer people, gay people, lesbians, trans people, especially Black trans people, fought to live, so I just want us to remember there's the structure, and it's important to actually understand what is happening when we're talking, even when we have friends that are have their intentions that are to help us, they may actually not. So I'm going to stop right there.
Thank you so much. One thing that you brought up so clearly, Sterling, was the cultural assumptions that we don't see, we don't talk about, ranging from who's deserving to what counts as therapy and where those ideas come from. And I just wanted to take a moment to allow Anna, if you have some cross-cultural perspectives to bring from Norway on these questions about the impact of the disease model on people who use drugs.
Yeah, so I would have needed to have some of my collaborators with me as being active in these policy debates and as drug users say something about the content. But I can say something about my impression, and that is so we don't really have the brain disease model of addiction, as that's not sort of a vivid presence in Norway. It's a lot of resistance to it, but there is certainly this sort of, you have to fit into a medical system in order to get treatment, and it's very restrictive intake criteria. It's a system still focused on the idea of abstinence, although it's sort of that has changed also during the last years. And what we see, and it's this heteronormative white impression. Norway is still, Scandinavia is still, struggling to really be more diverse, accept its diverseness. And the problem with the public, we have a public health system. There is in principle universal access, but when that access is perceived as restricted, there is a problem, and which creates lots of harm to the people within that process, because it goes with you. And I think I think Nancy can testify to this, that the medical system has never been. It's never about removing stigma. It's never about, because stigma comes in addition to a medical label. It always does. I mean, it's very seldom does not come with a label of stigma. And it very often, conceives of, you have to fit in. So I think, relating to what Sterling said, I think that's meant perhaps more sort of in public, in systems where welfare is really cherished and as part of our identity. It's maybe even more important to fit in and to be sort of equal to the rest. And I think acceptance of being different and being yourself is perhaps even more difficult in these circumstances, although you have better access to, social welfare and psychological support and these kinds of things, I think, in a public welfare system.
Thank you, Anna. So now I'm going to ask Nancy to help us pivot to another question about the scientific weaknesses of the disease model, which claims to be based in hard science.
Yeah, so one of these weaknesses are, of course, the epistemic injustices that I was mentioning earlier. But thinking about what Sterling said, I mean, one of the interesting things about innovation in the therapeutic sector when it comes to addiction, almost all of the innovation in that sector actually comes from movements, from social movements, from people like yourselves, right? Actively pushing and pressuring on access and what that means. And that is certainly true of the HIV/AIDS movement. And so I think that one of the weaknesses of the model is that neuroscientists simply don't listen to people who are involved actively in drug use or movements. And for that reason, there is what they call a translational crisis of the brain disease model. And this simply means, every model comes to crisis. Historians would be out of work if epistemic models, if ways of doing science didn't come to crisis and change, right? This model came out of a crisis. And so the brain disease model, however, hasn't really made good on its promises. It hasn't turned out to be all that useful. It hasn't really yielded the tools for cure. And they're still talking about cure, right? Not living with, but cure. We haven't really seen translation of basic knowledge into clinical tools. We haven't really seen new pharmacotherapies or non-pharmacological technologies to treat or prevent addiction. So clinical results of that model are few. We have the same FDA-approved pharmacotherapies, methadone, buprenorphine, and naltrexone, as we had in the early 2000s. And frankly, all of those, they cannot claim buprenorphine, right? All of those came out of pre-brain disease, behavioral and metabolic models from the 1970s, 80s, and so forth. So today's neuroscience response to the translational crisis, though, gives me pause. It really gives me chills. I am very concerned about where that model is heading. And due to its inherent weaknesses, I hope that we can talk a little bit about these neuromodulation techniques that they're putting forward now, like deep brain stimulation or transcranial magnetic stimulation, genetic modification. These are offered as solutions when people are defined as brain damaged. And that is where that model has unfortunately led them. So when addiction is framed as a neurodisorder, those who have it are defined as compelled, just as Nicole was saying, to engage in compulsive, impulsive, improperly disciplined, uncontrolled behaviors. I take all those terms from recent neuroscience articles. Today's core notion of impaired control, that's what it's called, is the defining, and here I'm going to quote them. I'm just going to quote our leading neuroscientists, George Koob, Nora Volkov, and our leading clinical translator, Thomas McClellan. Impaired control is the defining diagnostic construct hypothesized to be the result of gradual use-related damage to brain circuits, controlling reward sensitivity, motivation, self-regulation, negative emotional states, and stress tolerance. Imagine if you internalized that. Just exactly what Nicole was saying. I mean, this kind of internalization of this is who I am. Impaired control, to me, is full circle moral model, right? You can't hear or read a sentence like that and not think that that resembles yesterday's psychopathology or personality disorder, addictive personality, all of the very damaging, stigmatizing ways that we have had over time to talk about this condition that so many people live with. Yet these amnesiac neuroscientists seem unable to see or hear the damage that that does, that those kinds of constructs that they utilize in their science. I mean, these articles are published in major scientific journals. These are not obscure in any sort of way, but they are reinforcing their beliefs that addiction has only to do with the brain, right? As if the brain floats somehow free, not inside a person, a body, a society. And that, I think, is a real epistemic injustice that we have to overcome, right? With conversations like these, I think it can only be overcome by throwing all of our weight towards alternative models that make brain disease and brain damage a relic of the past.
Wow, thank you for that rousing critique. And I now want to turn to, perhaps I'll ask Sterling and then Nicole to answer what are alternative models communities are adopting to replace the disease model. Sterling?
So, yeah, this is, I mean, hearing Nancy go into like that, I guess to kind of bounce off of that, I feel so inclined to just reframe what we're even talking about. Like I always refer to body mind, like body mind, your body, your mind. This whole thing is together. The way that people are experiencing themselves is usually a full-bodied. This like and there are emotions and there's affect and there are collective experiences. There and that's at least from my experience. You know, I can say from my experience in terms of the ways that people have kind of gone from the prefigurative of like, oh, I am disease, I am a person that does not deserve anything, to, oh, I deserve housing, healthcare, and everything, has been through this collective model of organizing. And that's why I always go towards this idea of we're going to do this, we can only do this together. And having people individually talk to their individually kind of advocate, or even through their doctors, without having some sort of collective organization. And that means collective in so many ways, whether it's at the neighborhood level, on your block, in your clinic, in the prison, the organizing that's done in prison, the organizing that's done in mental health state hospitals. That is what I've seen that is what leads to freedom. And to be honest, what is to be done about that is where we're at, right? What is to be done? It is allowing for those connections to actually flourish. Because the people that are saving each other are other drug users. The people that are using naloxone on each other are providing healthcare, are providing emotional support, are other drug users. And I guess sex work has not been mentioned, but I will say other sex workers. Those are the people that are supporting each other here. And the ways that we have criminalized those, and I want to talk about like the actual laws, right? The criminal statutes for drug possession, for intent to distribute, for quote unquote prostitution, even some of the sex trafficking, the sex trafficking laws, quote unquote, that criminalize like sex workers, like those should be repealed, right? There are laws like drug-induced homicide laws, drug delivery resulting in death, which criminalize, friends that share drugs with each other with a murder sentence, instead of supporting people that have reached out for medical assistance to actually support the person that may or may not be dead at the time. They are then criminalized for that. They are punished. And that does not create bonds. That in fact makes us, I'll speak for myself. It makes me afraid. It makes me afraid because it makes me, the things that we have to like stay healthy for me are not being known, are not putting anything down in writing. I'm a lawyer, and I know I'm prepared for the police to go after you in any sort of way, whether you, as I tell people, don't put that on Facebook. Facebook talks to the cops. Your phone is constantly talking to the cops. There's so much to say. I feel like this, but it's like, but in terms of like how we actually, what are the alternative modes? It's like, we've always done this. We've always depended on each other, especially disabled people have always depended on each other to keep each other alive. But there are many laws that are coming in between us.
Thank you. Helps to have a lawyer in the house. Thank you. Nicole, would you like to comment?
Yeah, certainly. Building off of what Sterling said, I'll speak to the Vancouver landscape a bit. Much of what I'm going to say is broadly applicable, but Vancouver is a bit unique. I always say we're kind of in this epistemic war or kind of battle in terms of just like trying to identify what drug use actually is, right? And with all of these competing and conflicting paradigms, there is no one obviously answer, but in the Vancouver context, we have this really unique landscape where on the one hand, we have, I would say, a kind of self-identified liberal polity, a lot of folks who want to see themselves as progressive, who adopt the approach that, drug use of a certain nature, illegal drug use that is visible, is indicative of addiction, which is a disease. Simultaneously, we have folks that, of course, are always going to revert to solely wanting to criminalize drug use. And, in the downtown east side of Vancouver, there is a context in which there is this dialectic of extraordinary suffering. The ongoing legacy of settler colonialism, racial capitalism, all of those things are very, very visible. And the inequalities here are so stark. And with that comes really coordinated, incredible histories of resistance. And so there is this clash ongoing about what drug use is, whether it's indicative of addiction, in some cases, all cases, no cases, whether addiction is real and what is to be done. And so, through that, Milo, has come, these resistance movements, and I'll just like shout out a few of them. The Vancouver Area Network of Drug Users, VANDU, is a long-standing, like horizontally structured community group that helped spearhead, the the legal protections around Insight, North America's first safe injection site, have these incredible like mutual aid kind of networks set up and diffused throughout the city. The Drug User Liberation Front is a newer group that purchases drugs, tests them, packages them, and distributes them. Throughout BC, we have, I won't get too much into this, but basically our federal government has introduced legal pathways for implementing what's called safe supply, or legally prescribed pharmaceutical grade alternatives to the illegal drug supply. The program right now is basically up to each province to adopt. It's rife with barriers. It's wildly inaccessible. But there are pockets throughout at least this province where there are some examples of community programs that are structured and implemented in a way that at least attempt to give people who use drugs or drug users some autonomy. Those are ongoing in Victoria, which is all to say. I think at the end of the day, what I have learned being based in Vancouver, more than anything, is just the extent to which people who have been at this for years, for decades, resisting state oppression, are fully aware that the state will not save us, and have taken it upon themselves to do what is necessary to save one another's lives and to improve one another's quality of life, which I think gets lost sometimes when we only cite fatal overdose statistics. So that was a mouthful. And I will just add that you can approach these groups and you will not necessarily get told, you know, addiction isn't real. We may not be having those conversations, but that's all to say, like, no one is trying to negate the fact that people, me included, can develop like chaotic, compulsive relationships with drugs. Addiction, however you want to define it, like that locus of it can be real. But the departure is whether it's a chronic relapsing brain disease that therefore invites and warrants surveillance and control. So that was a rambly response. I'll leave it at that.
Oh, terrific. Thank you. So I think we'll go to our last question because I see the questions and Q&A piling up and we want to open this up to them. So the last question for discussion is how the coexistence of the disease model and medicalization, how its coexistence with criminalization of drugs impacts people. So there's a tension between upholding a medical disease model while criminalizing drug use. And I wonder if perhaps, Nicole, we could pivot back to you again, and then Sterling on that topic, you know, this apparent contradiction that we have both threads operating at the same time.
Yeah, absolutely. As I said earlier, there is that twinning of the sickness and badness paradigms, and we can't seem to decide on one or the other, probably because they are both oppressive. But in Vancouver, in BC, and across Canada, we are seeing increasing support for involuntary treatment, for example, which is functionally incarceration, of course, incarceration by a different name and done through a lens of benevolence, which in some ways I think is a bit more nefarious. And we see again kind of this confusion about whether drug use is a moral failing or a bad choice. And so that just really invites incoherent policies, but the incoherence is kind of the point because they're all rooted in the impulse to punish. And so, yeah, ultimately, I won't go on and on other than to say when we have, you know, provincial governments authorizing police, for example, or medical providers to involuntarily commit people, that is just incarceration by another name. Court-ordered treatment is the same. And so I will just end with saying that we can't dichotomize people who use drugs, drug users, into victims and perpetrators, which of course are racialized and classed and gendered and, you know, categories. And to truly move towards a model of drug use, including drug use that gets labeled as addiction, I think we need to, really just revisit the extent to which human rights are ostensibly a salient component of all of our lives, or should be, and return to the values of justice, of bodily autonomy, of consent. So I'll just leave it at that.
Thanks so much. Sterling?
What was the question again? Can you say the question again?
It was about the coexistence of, medicalized and criminalized approaches. Seems kind of contradictory, if you could comment
Medicalizing,
on that and
criminalizing.
its
Yeah, they
impact
seem
on
bad.
people.
No, get rid of them all. That doesn't make any sense. Yeah. No, it's like when you talk, so there's some, I'm thinking about the LGBT or the queer and trans space, and also gender as like the space where people don't, at least in the last few years, it's been very clear that there does not need to be a medical diagnosis for you to get access to hormones. Like, that's just what it should be. Like, there's nothing that should, and that's the same for other types of substances, right? Things are going to be different, but like in general, like people, like when we're fighting for buprenorphine or methadone or I feel like the goal, like the place where we want to be is decriminalized and like sufficient access to the medication with like sufficient knowledge about like how to use the thing. It's like there has to be comprehensive drug education, there has to be comprehensive sex education. Generally, people are going to be doing these things, but they need the knowledge of how to do them well, how to do them with each other, how to not hurt each other while doing them at the same time. That's just what it is. I don't know. I just don't have any interest in the medicalization part of it at all, honestly. I think that there are going to be spaces where there are going to be people that look weird and do lots of other things that also deserve to live and be themselves, right? I don't know. I'm a person that I've looked weird or been deformed like all my life, so like I always come back to that when I think about like what if somebody said that like you shouldn't, there used to be ugly laws, there used to be laws where like you could not go out because of what you look like, and there are, and I mean that's the way that it like public laws function anyway, like they will take you off the street if you are not conforming in the way that they want, or they will kill you, especially if you're Black, if you're not conforming. Somebody was just, I mean, let's just talk about it. Somebody was just murdered like on the public in front of all of our eyes that we got to see because they weren't acting in conformity, right? So like I just want us to think about like the ways that like I have no interest in the criminalization or the medicalization. If there is difference, there is room in our society for difference, period.
Beautifully said. And I think you're hearkening to eugenics as well. There's a criminalizing and a medicalizing approach to eugenics. So we have so many questions and so little time. I see that Nancy had something to add in on that.
I would say, and I'll answer the first question as well. I wanted to just say, I think that criminalization and medicalization have always traveled together. They are about, social control. And so you can't really separate out one for the other because there will always be aspects of control in each. And in particular, medicalization, the first question to us from the Q&A was Sheila Vakaraya's question on pre-addiction. It's interesting. In order to prepare for this talk, I've been writing something on pre-addiction and something on neuromodulation, these uses of new technologies. And pre-addiction in particular is a really interesting concept because it is about widening and driving further back in time a medicalization concept that, again, is being put forward by the chief medicalizers, the chief neuroscientists, and clinical translators would like there to be a concept of pre-addiction as there is a concept of pre-diabetes, so that medical providers can be reimbursed for providing treatment for pre-addiction. But again, to me, they're so amnesiac because this further pathologizes people. It further, particularly if it gets into the adolescent and parental realm, right? It is about basically diagnosing someone as having pre-addiction, as people do have pre-diabetes. Why? Since 2001, that's when the American Diabetes Association created the concept of pre-diabetes. Again, an entirely medicalization of a pre-state. So in the old days, right, of addiction medicine, there was addictive personality disorder, there was predisposition, there was susceptibility, there was vulnerability, right? There are all these ways in which our brains and our genetics, so going right back to what you were just saying, Helena, about eugenics, right? This is where they're looking. They're looking at, the molecular level, the genetic level, to see if they can find markers, biomarkers, of who is going to develop addictions later. As we know, exposure to drugs occurs within social settings, within markets that are structured, a bifurcated market, and is really not just about your brain, but really very much about the social world, the settings, who you are, how you access what you want, etc. And so it's a very interesting concept. I think pre-diabetes and pre-addiction are things that we should think very carefully about in light of the conversations we were having earlier on this panel about internalization of stigma, because this will teach people and it will sort of give an entree for the medical profession to provide drug education. And guess what form that will take? And so I feel like that concept is very much one that we should think about, along with these neuromodulation technologies, and the idea that you can change your brain, by having an electrode implanted to deliver deep brain stimulation, etc. And so,
Or
yes,
gene
I think
therapy,
we should be,
right?
but
You
yeah,
mentioned gene therapy as well.
yeah,
That's the
exactly. I mean, like
new
we're all
eugenics.
signed up for CRISPR to make sure that our pre-addictions are, subverted before. Yeah. So don't get me started, but that was my response to that first question.
I see some very vigorous response here on the part of Nicole and Sterling. Go ahead, Nicole.
Pardon me? Oh, yeah. Sorry, yeah, that just has prompted me to say that when we look at resisting the brain disease model of addiction, I think our critiques need to be rooted in like a political economic analysis of where it comes from and who benefits. And when we look at, in recent decades, the cottage industries that have emerged to predict, to surveil, to treat addiction, as well as institutions like not just the nonprofit industrial complex, but also the practice, for example, of physicians telling workers that they need to take regular urinalysis screenings to be able to return to work, and then also having those businesses on the side. Like, we can't extricate any of this from the capitalist economic system. And the abstinence-based addiction treatment industry, factions of neuroscience, these kind of predictive therapies and predictive treatments, and risk monitoring, like, we have to interrogate who is benefiting economically from the ongoing regulation, surveillance, and control of drug users, or even potential drug users.
Thank you. Sterling.
Just quickly so Anne can go. And I beg of people to help people that are currently experiencing homelessness, currently experiencing any sort of violence. Also, people that are using drugs and doing sex work, like, help them organize themselves. Like, I can tell you, when people came to us, when I do organizing, and they said, well, we're going to help people with mental health treatment and all. But like, they had to say that to the people that were experiencing homelessness at that time. When they looked them in the eye and they said that, and the crowd of people I was surrounded with laughed in their face and said, no, we need houses, I don't need treatment. That said something. That is the only thing that would say that could actually. There's no white paper I could write that could combat these, like the mayor and that council person that would say that, right? So it was just, for me, it just ends up being about getting to the ground and understanding it and working with people for a long period of time. for a long period of time, not just a year, but like throw out 3 to 5 year grants of like people to like develop into like the leaders in their, they're already leaders, but like, I don't know, sometimes extra skills and a little bit of, or a lot of bit of money that at least is life sustaining can actually help them do that, right? So I'm going to stop right there.
Thank you, Sterling, for bringing us back to the actual evidence-based mutual aid, grassroots political organizing. That's actually historically the only thing. Those are the things that help, right? Anna, do you want to add?
Oh, I just thought that that's a perfect end if we have to end now. So maybe so my comment was more about, and it's relating to some of the questions in the Q&A, that I think it's important for us all to remember, and maybe those of us doing some activism, that denying the medical model is not denying health problems to be treated and social support that can be argued through a medical lens. I mean, it's also important not to sort of throw away those who feel that they have been, fighting these abstinence policies for such a long time that they feel it's going back. So we need to sort of form these arguments in a way that make sure that, but maybe that's easier in the US and Canada. I don't know. In Europe, we're very careful about this at the moment. And in fact, many of the user activists groups I work with think that they need to argue still with the medical model, but carefully. So I think it was just to, include allies that you also have within the medical system to sort of argue for, for this change and for not being supportive of the medical model while still taking on board some of the medical assistance you might need, which is different from accepting the medical model, if that was clear at all.
Thank you. Yeah, so helpful. And sadly, we are out of time. I do want to end by acknowledging some of the organizations that there's so many individuals involved that I can't name them all, but I wanted to acknowledge some of the organizations that have given us support, since I didn't do that at the beginning. So the Yale program in addiction medicine, which is the host of the webinar link we're using, Foundation for Opioid Response Efforts, the UCLA Center for Social Medicine, Urban Survivors Union, now rebranded as National Survivors Union, and the Drug Policy Alliance. So those are just some of the organizations that have helped us to put this on. And I hope you join us for future seminars. What a fantastic conversation. Thanks again to the panelists. Bravo.